Thank you, Dr. Kreutz, who none of you will be surprised is from our division of cardiology. And then we have the division of gastroenterology, the legendary Dr. Raj Vuppalanchi.
Legend in my mind, at least. Hi. As you probably have seen me before somewhere on the campus, I actually did a combined clinical pharmacology and GI fellowship, and I'm a product of Dr. Flockhart's tutelage. So you've seen how pharmacogenetics could potentially be a game changer, but I'll share you my experience as to how I have been using it in my practice over the last 3 to 4 years in real world, both at my practice at the university hospital and at our GI clinic at Wishard. So this is real. I'm going to pick hepatitis C as the topic to discuss about pharmacogenetic usage and personalized care. This is a patient of mine, 41-year-old white woman with hepatitis C, genotype 1A. There are six genotypes of hepatitis C. Type 1, 2, and 3 are seen in the United States, with 1 being the most common and difficult to treat, less response to therapy. Viral load of 3.2 million international units per ml. She is a business executive, works full-time, has some mild depression that is medically controlled, 6 drinks of alcohol per week, BMI 34. She does require travel and meet with clients. So it's important to know my patient, to customize the care, to discuss about potential side effects, especially with the therapy that is long-term. So as I see the patient, all these things are running in my mind. How can I predict response to therapy? There are some that are obvious, which are already seen on the blood test results, which is genotype, viral load. Some that are obtained with history taking with regard to mental health issues, substance abuse, adherence to therapy, and then some that I perceive on examination, whether advanced age, advanced fibrosis, cirrhosis, is there co-infection, too much iron in the liver, diabetes, prediabetes, race, Caucasian versus Hispanic versus African American, fat in the liver, and the weight of the patient. Each of them have been shown to be a predictor to response to therapy. So all these things are going on in my mind, and some that are very favorable with regard to response to therapy are female gender, younger age, no co-infection, and Caucasian race. Not favorable are obviously active alcohol use, lack of adherence to therapy. Genotype 1, as I said, is less response to what we have, and high viral load and underlying insulin resistance or diabetes. So one thing that stood out for a long time was that Caucasians have better response to therapy. African Americans have the lowest response to therapy. And we just left it at race with no explanation until polymorphism was discovered. Basically, this is from the Duke group. They took leftover samples from a large clinical trial and divided the samples as those who responded and those who did not. They did a GWAS study, and you've seen Manhattan plots. I'm not going to show you the same. But in that plot, one polymorphism, that is 3 kilo base pairs upstream of IL-28, which is interleukin 28B genotype on chromosome 19, that popped up. And you have 3 possible alleles, CC, CT, or TT. And this is how the allele distribution was in European Americans, African Americans, and Hispanics. Here on your y-axis, you have the SVR, which is sustained virological response, or for simplicity, you can use it as cure rate for Hep C treatment. And as you see, if you have CC genotype, your cure rates are very high. And this is across the race. If you have TT, the cure rates are lower, and this seems to be across the race again. So then they looked at the distribution of CC genotype across different racial groups, and you see that the prevalence of CC genotype is the lowest in African Americans. Somewhere in the middle is the Hispanic and Caucasians, and the most is the East Asians. So all of a sudden, we were able to explain why African Americans responded lower to to the same therapy compared to Caucasians. So we were able to go beyond the color and actually explain at a genetic level. And this was almost 3 years ago. So the distribution is a similar figure to this in a different pattern, but your CC is much less common in African Americans. Okay, there's a question here. Prior to approval of direct-acting antiviral agents, cure rates to pegylated interferon and ribavirin therapy were lowest in patients belonging to which race? I hope it's 100%. Yeah, somebody doesn't like me. Okay. Okay, both the questions are right there. This is similar. Poor response to pegylated interferon therapy in African Americans was due to high prevalence of which IL-28B genotype? Sorry. Okay, whoever doesn't like me, please. Oh. Well, it's a negative of negative, I guess. So I said African Americans and poor response is because of high prevalence of TT. So CC is good, TT is bad. That's the reason why the answer is this one. Okay, so what did I do? In 2010, when she came around, we did the IL-28B genotype test, and it came back as TT. Liver biopsy showed early scarring, and I told her to wait until newer agents are approved, minimize the alcohol consumption, if not abstain. So I was still able to intervene, prevent the progression by removing alcohol from the picture, and I reassured that the situation at that time point showed very little scarring and very poor response to therapy. And with her lifestyle, we did not feel that that was the appropriate thing to put her through therapy at that time. Fast forward a year later, 2 new direct-acting antiviral agents were approved, and these were unfortunately to be used in conjunction with pegylated interferon and ribavirin. The newer therapies have much higher cure rates, almost 80%, with almost 50% requiring only 6 months of treatment, but there is still additional patients who may require the complete 48 weeks. Again, going back to what information I had with regard to her IL-28B genotype, she was TT. So we were able to tell her that perhaps she would not be a candidate for response-guided therapy. She probably will end up with 48 weeks of treatment. because she's not going to meet this criteria of becoming undetectable at week 4 and week 12 of therapy. So again, yes, there were improvements in therapeutics, but based on her genetic makeup and based on her lifestyle, her other commitments in life, we didn't feel that was the right thing to do at that time. We already reassured ourselves that the amount of fibrosis in her liver is still early. So when she came back to see us, she quit alcohol completely. She has lost weight. She's trying to do whatever she can from her point to change the negative prognostic factors, but genetic makeup is the strongest predictor more than the environmental factors. So again, concerns with regard to interferon-based therapy, response and duration of treatment, these were all discussed, and we felt that we needed to postpone treatment. And this is very critical. This was an informed deferral. We are just not saying, no, come back. We use the most available information to make a very personalized, informed decision to not pursue treatment. So she's currently awaiting non-interferon-based therapies that could be approved as early as later half of next year. There is some data with regard to combination. These are 2 direct-acting antiviral agents without interferon, without ribavirin. The company is putting them in 1 pill, so it's going to be a poly pill. 8 weeks of treatment for genotype 1, never been treated, 95% cure rate. This is how much change in therapeutics is going to be in the field of hepatitis C. So informed deferral made sense, and we used pharmacogenetics to do that. Now, questions arise. Well, if your therapy is so good, why do you care about pharmacogenetics anymore? Maybe you already missed the boat. There's no role for IL-28B genotype. I don't know. I think it may be more of a financial decision. There will be a lot of competition, too many players in the market. There's going to be a price war. If the combination is very strong, perhaps the host genotype may not play a role. If the combination of drugs is weak, perhaps the host genotype may play a role. If this is anticipated to cost $80,000 to $100,000 for 2 months, Medicare, Medicaid, whoever says, you know what, pegylated interferon and ribavirin is $10,000. If it is CC genotype, why not use pegylated interferon and ribavirin? It's probably 8 or 9 times cheaper. You will have the same response rate, but side effect profile sucks, but it's cheap. It's very cheap. So I don't know. That may be what may happen. People who have weaker combinations are going to drop the price. People who have stronger combinations are going to ask for a premium. Cure rates may be the same, but the cost of the drug may play a role, and pharmacogenetics may have some role there. Okay. We have not had any problems with insurance paying for the test. I've ordered it Wishard, I've ordered it IU. Patient never complained that that particular bill was not paid. It costs anywhere from $300 to $400. It's commercially available. This test, it was published and used right away within a few months from the time it was shown at ASLD. Some people adopted right away to use it the way I used. Some people never got into it, and they might not ever get into it.